Hi. So thank you very much. Thank you for having me. I very much appreciate it. I feel honored and flattered to be here. I'm a little worried about being the only thing standing between you and lunch. So, but I was going to be presenting later this afternoon, and then Ibrahim thought that it would be for me to speak now. So I hope that's okay. And also, Ibrahim could easily give this presentation. He has an article on LinkedIn that hopefully you've all read. He's an expert in the same area. And so, anyway, with that, I will get started and try to figure out how to advance slides here. Okay, it worked. So, I'm going to be talking about our school's educational pillars, just mention them. Then I will briefly talk about health system science and define it. Then I will focus mainly on our school's approach to teaching HSS, that's what I'll be calling it. And then I don't know if we'll have time for Q&A because it's lunch, but I'm happy to talk afterwards if there is a time for Q&A. So, the two traditional pillars of medical education, at least in the United States, are biomedical science, which of course is biochemistry, physiology, anatomy, all the underpinnings of understanding delivery of healthcare. And then there's clinical science, which is prevention, diagnosis, and treatment of health and illness. And also it's focused on optimizing the health of each patient. And I make that distinction because health system science is much more focused on communities. And then we bring in health system science. I'm going to spend a few slides defining it, but one definition is that it's the science of how human relationships, not just one person, but more than one person, organized into systems influence health. And we talked in our small group, and it was suggested that I give a quick interjection of how our school organizes its curriculum, because that will give you a context for my description of what we do with health system science. So we have a case-based approach. We have flipped classrooms. Our students are broken down into groups of 8 with 2 faculty, a physician, and a biomedical scientist team teaching for about 2-month blocks, which should instantly make it clear that they're not only teaching their area of expertise, they're teaching across the spectrum, and we prepare them for that. We do not have a biochemistry class, we don't have a histology class. We integrate everything into these cases. And so they're learning the physiology and anatomy of the heart at the same time that they're learning about prevention, diagnosis, and treatment of myocardial infarction. But they're also learning at the same time that women receive worse quality of care than men. This is health system science now. For myocardial infarctions, for heart attacks, and that people of color, people who are black or Latino or other non-white backgrounds in the United States receive worse quality of care than people who are white. So we integrate that all together into the same cases, into the same classrooms. So health system science provides a foundation and a framework for the study and understanding of how healthcare is delivered, how health professionals work together to deliver that care, and how the healthcare system can improve patient care and healthcare delivery. And we have viewed this as a really crucial component in medical education, something that in the US had often been left out of education, so that healthcare professionals would prescribe medications, prescribe treatments with no idea what they cost. They would be asked to measure quality of care, and they would balk at it because they didn't understand it, and did not understand that we all make mistakes, we all can do better, and we engage in quality measurement and improvement so that we can get better and deliver better care. So there was really a feeling that we need to bring all this material in an organized way into the curriculum. And the American Medical Association is the organization that really pulled together this whole field. Much of this will be familiar, much of what I talk about has already been talked about today, but this was an effort to bring it all together and give it an organized footprint in the curriculum of American medical schools. We're the first school to have an actual department of health system science and to make it one of our 3 major pillars, but other med schools in the United States have already been integrating it in various ways, and more are doing so. So here is our list of topics. There's all sorts of articles out there, and there are other topics that are sometimes included or sometimes removed, depending on the particular school. So quality and patient safety, INCRE, which is another word for research, healthcare and social systems, community and population health, health information technology, and systems ethics. And I'll point out that I'm going to walk through each of these. So to start with quality and patient safety. We want our students to understand how and why we measure quality and safety. And safety, of course, is the whole idea of errors, making errors and trying to stop making errors. Quality and performance improvement, learning from our mistakes. Interprofessional teams, which we've already heard a lot about today, but that is, working on interprofessional teams is one way to improve quality, to have fewer mistakes. And then at our school, our students conduct a quality improvement project. One year they worked on hypertension management. And so they were divided into groups and worked on these quality improvement projects, and they had a lot of support from people with expertise in quality improvement. And an example is coming up with a text messaging system to remind people who have hypertension, particularly challenging to control hypertension, sending them messages to remind them to get the regular blood pressure checks and to fill their prescriptions and take their medications. And this is just a graph of a quality improvement activity over 20 years at Kaiser Permanente. Kaiser Permanente is the large system that Samir mentioned that funds our medical school and gives us our name. And more than that, it is very much integrated with our school. So this goes over 2 decades, 2001 to 2018. And you can see at the beginning, this is about the percentage of people with effective blood pressure control. The blue is our system. The orange is similar systems across the U.S., the average of them, and green is the U.S. in general. So U.S. in general wasn't doing as well on this. And what happened is, in 2001, it was made to be a priority for Kaiser Permanente, so it had leadership emphasis. There was a paper registry, like lists, printouts of people with hypertension and uncontrolled hypertension. And then there was adoption of guidelines. And then you can see it started going up, but it was going up in HMO, health maintenance organizations anyway. And then in 2004, there was an algorithm added and other things were going on to try to improve the care. And I should say, you can see at the bottom JNC 7 and JNC 8, those were new national guidelines. ACA in 2010 is what we often call Obamacare. That was President Obama's improvement. I guess that's debated. Many of us think it was an improvement to the healthcare system and the way it was organized, and it certainly increased access to care so that more people could actually get healthcare in the United States. And then you can see more was going on over time at Kaiser Permanente, and eventually there was an electronic registry, not just a printout, and medical assistant visits to get your blood pressure checked no longer had a copay. Various things were being done. And the students learned how to do these kind of charts looking over weeks and months, not 2 decades. Just wanted to show an example of the success at Kaiser Permanente. Great improvement in having blood pressure control. So moving on to INCRE, we teach them the fundamentals of clinical epidemiology and statistics. We teach them basic research methods. We want them to be, we're not going to be researchers based on what we're teaching them here, although some get master's degrees and PhDs at neighboring universities. But we want them to be informed consumers of research. We want them to be able to read a paper and feel like they understand it and the methods were valid. We teach them about clinical appraisal and evidence synthesis, the idea of synthesizing multiple studies that they might read that often disagree with each other and figuring out what to do, how to make decisions about what they should do for their patients. Implementation science, the whole idea of studying the uptake of evidence-based processes and practices in the real world. The whole idea that when we develop a new medication or a new approach, it can often traditionally take 15 years for that to get out to general practice in the United States. It's getting faster, but it still takes a very long time to get everyone to be aware of new processes and to start implementing them. And then our students conduct a scholarly project. This is over 4 years. Many of them publish their projects, publish their papers, and this is mentored, and it's really an effort to help them learn if they like research. And some of them do much more than one project. Moving on to the next topic, healthcare and social systems. We want them to understand the health systems in the United States and actually beyond the United States. So in the US, we have public insurance, we have private insurance. Our private insurance is sometimes organized around you, the physician or the clinicians get paid for each thing they do. Other times it's capitated. There's a monthly amount that you get for all the patients in your practice, and you have to make it work. Some will be very sick, some won't need any health care over a number of months, and you take all that money that you get and you provide health care with it. And there's other systems as well. But the point is, we want our students to understand these systems. We want them to understand that there's more than just the healthcare system. There are social service delivery systems that can affect the housing that their patients have, the food support if their patients are under-resourced, and that these are very important for health. Health policy, the role of laws and regulations and how those affect people's health. And then the integration of healthcare and social systems to improve health. The idea that in a city, the health department and the education department might team up to organize having clinics, put school-based clinics added into the system so that the students who they're finding never make it to the healthcare system can have easy access to healthcare. Moving on to community and population health. A lot of people have mentioned the social determinants of health. We call them the social, economic, and environmental factors that influence health. This is the whole idea that what goes on in the home, the workplace, the school, the neighborhood can have a lot more influence over people's health than what we do in the clinic. And we certainly should know about it. We want our students to learn how to ask the right questions and understand how much what's going on in their patients' lives may affect their health, their ability to take their medications, their ability to get their kids in, to get vaccinated. Health equity, the whole idea of whether we are meeting the needs of our patients based on who they are, what their demographics are. So whether our phone system or our website allows our patients to be able to request a certain or view the information in a certain language, the language that they speak. I was saying in our group that when I flew out here, and because of all the flight delays, I had very long flights, and I was amazed at how many choices I had for what the language of the movies were. And we don't have as many choices in our health system when people are going into our websites, and that's something that is very important for us, or we feel it's important for our students to understand. Allowing their patients to be able to hear the information or see the information in the language they're comfortable with. Community health partnerships and advocacy, we want our students to understand how much there are community organizations, non-governmental organizations that can really support their patients and help them and help their patients. Community health resources and needs. We have communities in the United States that have no grocery stores. There's fast food, there's McDonald's, and there might be these little, almost kiosks, little small fast food type things at a gas station where you can buy a lot of sweets. But there's no fresh fruits and vegetables in neighborhoods, low-income neighborhoods around the United States. We call them food deserts. We want our students to understand what's going on in their communities. Some of our students come from these communities, but not all. And then our students are all assigned to what's called a federally qualified health center, a community health center that is serving lower resourced communities. And they do a project in their service learning project. Someone else already mentioned service learning. The idea that the students are learning, but the community, is also benefiting from this project. This is where they really get a lot of understanding of what goes on in under-resourced environments. And this is just an example of what people are calling social determinants of health. So Beverly Hills is where many rich people live in the United States. I assume that's famous around the world. Watts Tower is probably not famous, but it's a structure in one of the lowest income areas of Los Angeles. It's probably 15 to 20 miles from Beverly Hills. And you can see it's more than a decade difference in life expectancy, whether you live in the Watts Tower, South Central Los Angeles, versus whether you live in Beverly Hills, really south of LA, is the Watts Tower. Moving on to health information technology, we want our students to understand how IT can be helpful or have challenges. They of course learn about using electronic health records, and then decision support, they learn how systems can automatically recommend that your patients at the age where they need a colonoscopy or they haven't gotten their mammogram yet. I was mentioning in our group that when you go into orthopedics at Kaiser Permanente to get a consultation for a knee replacement, if you haven't had your flu shot, it pops up on the computer and the receptionist will say, we can give you your flu shot right now. And so that kind of integrated system I find very appealing, certainly as a patient I do. Population health management, the idea that we run the data and we compare all our doctors to see if some are, their patients are getting preventive care more than other people's patients. And then we help them figure out how to do better. But we also look at neighborhoods. Are patients from certain communities getting better quality care than others, and we explore why. And then AI scribes, I don't know if you're using them yet here, they're new. The idea of artificial intelligence is listening as you interact with your patient and producing a whole summary, history, physical, diagnosis, and treatment. And AI scribes are now proposing additional diagnoses and additional treatment options. All of this is new, all of it needs to be studied. There are, of course, hallucinations and anything that artificial intelligence does, and their material needs to be reviewed. But we want our students to be ready to go into the workforce, so we're teaching them about artificial intelligence. They're not allowed to use the AI scribes, they need to do it themselves, but they are observing it and learning about it. Communication tools, patient portals, the idea that much of the communication between physicians and nurse practitioners and patients is going on through apps, through portals that allow a private, protected message to be sent and back and forth communication. We also teach them about data security and data ownership and all the legal and ethical issues that go with who owns the patient's data. Moving on to systems ethics. Individual ethics are generally the idea, and I know it's more complicated than this, but you do what's best for your patient and their family. But we want to understand systems ethics. So the idea that when you have a bus crash or a building collapse and all the patients are coming to your emergency room, you're making decisions that will affect who will live and die. You're no longer able to do what's best for each individual patient, at least usually you don't have the resources. And the decisions we made have huge decisions that have huge impact on individual patients. The same way when our insurance companies decide whether or not to cover Samir's expertise, assistive reproductive technology. Some of our insurance companies in the US cover them, some don't. That has a huge impact on people's lives. If they're rich, they can still afford to do IVF. But if they're low income, it's just not an option for them. And so we have huge decisions being made by insurance companies, healthcare systems. We want our students to understand how that all works. So that was the 6. There are 2 more I just want to touch on that are really underlying everything. And the first is uncertainty. The idea that diagnostic uncertainty. Symptoms can be ambiguous. Shortness of breath can be heart disease, lung disease, anxiety. There's a lot to figure out, and I know we all know this. Prognostic uncertainty. Predicting the course of a disease, it's so variable across patients. That's hard to do. It's probabilistic thinking. Therapeutic uncertainty, which medication is best. Students come in assuming that there are yes and no answers for everything. And we work very hard to help them understand that this is all about probabilities. We often hear the art of medicine, not just the science of medicine. Well, the art is often understanding probabilities. And certainly different patients respond to different therapies quite differently. And we really work hard so that our students aren't shocked by this when they're out in practice. And complexity, the idea that just this is all very complex. And the example, one of the examples I put into the slide, prioritizing, when you're making decisions, prioritizing survival until a target event versus longevity. Meaning, students come in assuming that, of course, more life is better, longer years are better. We help them understand patients' values have to be taken into account, and it's ultimately a patient's decision what kind of treatment we provide. So that some patients care more about length of life than quality, and vice versa. You know, a patient might say, and this is also an example I gave in our small group, you know, when they're being treated for cancer, all I care about is that I make it until the birth of my grandchild in 6 months. I want a treatment that guarantees that that does not have side effects where I might die in the next 3 months. I want to live for 6 months, and then after that, obviously I want to keep living, but I don't care as much. Versus someone who wants to live as long as possible, is willing to take a chance of dying, a 30% chance of dying in the next few months, but a 70% chance of living quite longer. Those are complicated, they're hard. We want our students to understand that these are hard and know how to think these through. We do have some cross-cutting threads. Advocacy, I'm just going to name them, advocacy and leadership, equity, inclusion, and diversity. I already mentioned that in the US, women receive worse quality and people of color receive worse quality for MIs than white people. That's true for many conditions. And then interprofessional collaboration has been discussed a lot. Someone asked me in our small group about health promotion. That's actually our fourth thread, but it's not housed under health system science for us, but it's very much aligned with health system science. And I have this slide on interprofessional collaboration. The topic has been covered so much that, given that lunch is looming, I will just give one example. So we don't have our own nursing and pharmacy students, but we've teamed up with 2 other schools that are on the right, and we bring our students together 4 to 5 times a year, depending on the year, and they engage in exercises together. And the idea is, at least in the US, physicians often think that they know everything, and nurses are mini physicians, and you know, a doctor can do anything a nurse can do, which is obviously blatantly untrue. And we want our students to see nurses have skills, it's its own profession, and you can't function without working with a nurse as your peer and colleague and partner. And so we want them to learn right from the beginning what it means to work together. So they work on these cases with simulated patients. We have actors who are functioning as simulated patients, and they work through how to actually prescribe IV antibiotics in the hospital, which feels very straightforward. But the doctor writes a prescription, the nurse takes the prescription and processes it to go to the pharmacy, or it can be automatic in the system, sometimes depending on where you are. And then the pharmacist checks whether there are drug interactions, fills the prescription, sends it to the nurse who provides it. All of them, of course, are supposed to be checking for allergies. But they're all doing it, they all have a role to play in something as straightforward as providing IV antibiotics in a hospital. And we have a number of these where they work together and see that they each have a role to play. So I'm going to end it there. If you have questions, I don't know if you can ask them now if we have time, but I'm happy to answer now or, you know, if we're all milling about afterwards.
The shortage of time, we'll just move on with our lunch. Hamımızı nahar yemeğine davet ediyorum. Biz nahar yemeğine gideceğiz. Biraz onu kısa tutacağız, biraz vaxt açısından. Ve son sesiyamızda da biraz vaxt, qənaət vaxtında bitirmək istəyirik. Çünki şuraya gedəcək isə hava qaralmadan şuranı görmək vacibdir diye düşünüyorum. Değil mi?